Have you ever wondered about the benefits of testosterone and those benefits that it has on the heart? We have a famous UK cardiologist joining us today to discuss this. So if you'd like to find out more about that, keep watching. Hello, so welcome back to a Balance My Hormones video. We are here with Dr. Sanjay Gupta, who is he's a pretty famous cardiologist. He's got a great YouTube channel, really good information on there, explained really well. The way he puts it across, I think most people can watch that and get really good information from it. So he is based out of York. The channel is called York Cardiology. So thank you for coming on.
Thank you for having me.
So today, we obviously testosterone is something that we talk about a lot, TRT, HRT. We are going to discuss a few topics and get Dr. Gupta's insight on testosterone and the benefits for the heart, because there's a bit of, I think, misinformation about it out there. So I know this is an area you're pretty familiar with. So what are the benefits of testosterone on the heart?
Yeah, I think the first thing to say is that what we know, testosterone, as you know, as your readers I'm sure understand, is the principal male sex hormone. And we know that in general, as men get above the age of 40, testosterone levels start dropping. We also know that as men get above the age of 40, their overall cardiac risk and overall risk of mortality starts increasing. So it appears that overall cardiac risk starts going up around about the same time as testosterone levels start falling. What we still don't know is whether they're both simply a consequence of aging. They're just associated, there's no causative role, or whether in some way testosterone is protective against cardiac risk. So this is the observation that made people get interested in testosterone. And I can talk to you about exactly what we know so far about testosterone, but testosterone does have many benefits other than what it obviously does, which is it is responsible for our primary and secondary sexual characteristics. It's responsible for our libido, etc. But it also has other beneficial effects which are very good for the heart and the circulatory system. In particular, it's a vasodilator, so it opens up blood vessels. Anything that opens up blood vessels is generally a good thing, unless it does it to an extreme, because it allows blood to get to where it needs to get to with more ease. Testosterone is also an anti-inflammatory, and therefore that's a good thing, because virtually all chronic disease, the kind of root cause is inflammation, and therefore anything which is anti-inflammatory is always worth looking at in a bit more detail. We know that those people who are testosterone deficient or low in testosterone tend to do badly, but I can go into that in a lot more detail as we progress.
Okay, great. So, Mike, you got a question? Do you want to go in?
No, it's interesting. You mentioned the fact there's a vasodilator, and on the anti-inflammatory side, is that more to do with it kind of quieting down the cytokines and more the cardiovascular side for atherosclerosis, or?
Yeah, I think the first thing to say is that when we, when you look at, I guess the most important thing is, what is the outcome measure? Okay, it may be good, it may be doing those things, but do those things actually translate into meaningful benefits for the patient? So when we look at studies, because that's what I deal with, I'm more interested in how does it translate for the patient rather than what is it doing on a microscopic level. There's no merit of whatever it's doing if it isn't translated in some way into patient benefit that the patient can in some way measure, or we can measure. Mm-hmm. So when we look at testosterone and overall cardiac mortality, there was a publication by a guy called Corona who studied 1,178 articles to do with testosterone in the heart. And he concluded that testosterone deficiency was associated with both an increased overall mortality and increased cardiac mortality. There have been studies where they've looked, small studies where they've looked at patients who are testosterone deficient and the magnitude of atheroma, coronary artery disease, that they may have. And what they've found is an inverse relationship. A population of patients with the lowest testosterone levels are far more likely to have the severest coronary disease. Again, very interesting. Now, that may be because of its vasodilatory effect, because blood's getting through easier, and therefore you're getting less kind of, wear and tear of your blood vessels trying to get this blood through. That may be the reason, but that has been observed. We've also found in heart failure patients, again, another really interesting group of patients. And if you look at all stages of heart failure, mild heart failure, moderate heart failure, severe heart failure, you compare testosterone levels in a heart failure population with an age-matched population who don't have heart failure, the heart failure population in general will have lower testosterone levels. The worse the heart failure, the lower the testosterone levels. Another really interesting observational study.
So if you had a patient who had some sort of cardiac myopathy, let's say left ventricular hypertrophy, and was on testosterone treatment, would you be okay with them continuing their treatment?
Absolutely, because again, whilst there is this observation that heart failure patients have lower testosterone levels, the question is, can you do anything about it? Does treating the testosterone actually make things better? Because if it doesn't, then what does it matter? You can't do anything about it. It's only worth worrying about things you can do something about. And so when we look at testosterone replacement in testosterone deficient heart failure patients, it appears that replacing testosterone in these patients is associated with an improved exercise capacity and functional status. In one study, there was a 16.7% improvement on exercise distance on a 6-minute walk test. So they could increase their exercise capacity by 16.7%. That's incredible. You're trying to make a difference to the person's quality of life. If the person can do more, their quality of life gets better. And so I would have no problems at all.
That's interesting.
So, I mean, isn't it interesting that when women also lose their hormones in menopause, and obviously testosterone can be affected as well. Women have testosterone and need it, but obviously estrogen, which men also get from their testosterone, that I believe, and you might correct me, but I believe the incidences of cardiac events and cardiac disease in women when they lose their hormones is also, it goes up post-menopause. Yeah.
It's interesting, isn't it, that until women become post-menopausal, their risks are a little bit lower than men. Men have a higher risk, and then the risks equalize after menopause. So this suggests that there may be some protective role from the hormones that exist before menopause, namely estrogen. In fact, there was some suggestion at one point that, hormone replacement therapy in women was harmful. But actually, when you go back and you look at the data and when people analyzed it, it wasn't really. So at this point in time, we don't think hormone replacement is a bad thing in women who are postmenopausal. But we don't have any large-scale trials to say, oh, it definitely prevents risk. So we would recommend it if someone needed it for hormonal issues, etc. But we don't routinely prescribe it in postmenopausal women as yet to prevent bad things happening. So this is the current status at the moment. Same with men. As you know, some of the testosterone gets aromatized to estrogen. And it seems that little level of estrogen is protective. It seems to have beneficial effects on the lipid levels, etc. And when that falls, the lipid profile gets a bit worse. And therefore, in some ways, maybe getting their testosterone levels up if they're deficient, may be a good thing from that side as well.
So it's like an anti-inflammatory benefit, potentially with the protection of the heart and the cardiovascular system and increased blood flow, and maybe the bit of conversion to estrogen as well, as sort of this whole mix of providing that cardiac protection that sort of was reflected in those studies.
And even in diabetics, in testosterone deficient diabetics, if you give them a testosterone replacement therapy, their HbA1c improves, their fasting blood sugar levels improve. And most importantly, the fact is that if you're testosterone deficient, you just feel miserable, right?
Yeah.
So whilst it's okay that we would like to do all these good things in terms of the long run, you want it to benefit the patient what we mustn't forget is that the more important thing is quality of life. How does that patient feel now? And I think that people who are testosterone deficient, as you probably know yourself, don't, they have reduced libido, they have erectile dysfunction, they have reduced energy levels, they have bad mood, they have increased irritability. I am sure there's a higher prevalence of things like depression, psychological distress, etc. So everything gets worse. To my mind, that in itself, if you can get that better for the patient, then that's great. If as a byproduct you then develop, you also confer some kind of long-term benefit on them, which sometimes the patient may never realize, because how does he know? Then that's good. The most important thing from my perspective is to know that it doesn't harm you in the long run. And to my mind, at this point in time, there's really no good convincing evidence that testosterone is harmful. Testosterone replacement is harmful. Everything points to the fact that it actually helps people, both in terms of quality of life, but may also alter, beneficially the overall risk from the cardiovascular disease.
I mean, that's pretty great for some of our listeners to hear, right, Mike? And the diabetic and HbA1c and sort of insulin control. I mean, I know with more muscle mass, the insulin sensitivity can be improved, and I know muscle mass in itself is definitely correlated with better health outcomes and things like that. And we have seen that, and completely backs up what you're saying with the diabetics. But even in men that are pre-diabetic or maybe have like a slightly higher HbA1c or insulin is fasting insulin is particularly high. Those things improve when you're just restoring the hormones. So I know insulin presence in the body, I believe, is quite inflammatory in the cardiovascular system. Is that right? So I can imagine if you're reducing the amount of insulin that is exposed to the body, you're obviously protecting the cardiovascular system as well as all those other things you just mentioned.
Yeah, I mean, I think the first thing I would say is that the whole of diabetes management is to my mind seriously lacking, in the sense that everyone treats diabetes as a number. You hit the number, okay, and the number is decided by a bunch of experts. There is no real major kind of, it's not set in stone. They can change the number whenever they want. But you hit the number, then you become diabetic.
Yeah.
Then you get given a medicine to reduce the number, and suddenly you're okay. To my mind, diabetes is not a number. Diabetes is a process, okay? And that process may manifest with the number you're looking for at some point during its course. It doesn't mean that you weren't having the harmful effects of the process happening to you even before you hit that threshold, which has been decided upon by man. That's the first thing. And the second thing is, if it's a process, then just making the number a bit nicer may not necessarily sort the whole problem out. Yes, if the number itself starts causing you harm, so if you've got a ton of blood sugar and that blood sugar itself is going to harm you, then making the number better is a good thing. And that's why diabetic outcomes are improved with the currently used, but by bringing your blood sugars down, your diabetic outcomes are improved. But the diabetic outcomes are not, they haven't been revolutionized, because perhaps our treatments are only targeting that damage which is done by the number, not the process that has caused the number to go up in the first place. And what is becoming really interesting now in diabetes management is that, we're always seeing patients who come into my CCU with heart attacks. And I talk to the doctor and I say, what are his risk factors? Oh, he's diabetic. He's been on metformin. Well, why was he taking it if wasn't he taking it to prevent this from happening?
Yeah.
But we see it all the time. So to my mind, maybe diabetes should be treated as a process. And very interestingly, now you have these new medications called SGLT2 inhibitors. You may have heard of them, empagliflozin, dapagliflozin. Here, these are very interesting medications because they don't seem to lower blood sugars very much.
Yeah.
But they seem to transform outcomes. They seem to have a significant benefit in terms of long-term survival in patients with heart disease, heart failure, etc. And so maybe these have anti-inflammatory effects. Maybe they have anti kind of other stuff going on. Maybe they're tackling the process rather than just the number. So here you have a condition. You have testosterone deficiency may be a process which contributes. We certainly know that testosterone deficient men have more fat than muscle. Mm-hmm. We know that if you're obese, you're far more likely to be testosterone deficient. And we know that those people who have the lowest testosterone have at least a two-time higher risk of developing type 2 diabetes.
It's crazy.
So it makes sense to me that you don't just treat the number, but you tackle the underlying processes as well.
And this is really important. I was just going to say, I think we're going to say the same thing about levels of testosterone, right? In men, in terms of where a man becomes suitable for testosterone replacement therapy, there isn't evidence to say there is a number here that all men, when they reach that number, they start to feel all the effects of having lower testosterone. And I think that's really important because, if you've got autoimmune disease or anything, or just the aging process, that maybe you started out at a certain number and then there is something gradually going on, whether it's environmental, whether it is, functionality, consistency of production from the testicles or the signal from the brain or the sensitivity of one to the other. And it takes years for a man to start climbing down, and maybe depression starts hitting because of the drop in testosterone, because of the disease process happening. That man will not get help unless they meet a number that we have spoken to doctors in the US, for example. They have their 300 nanograms that sat on the board where they just decided on the number because it sounded good, right? There was no sort of, this is based on evidence. And so there are men, there can be, and I'm sure there are millions of men that are in this sort of between the process beginning, having worse quality of life and probably poorer health outcomes as well, and then meeting the number that is allowed to give to, for them to be given TRT. So I think that alludes to that as well. And maybe it depends on your outcome measure, right? I suppose the thing.
Absolutely. Yeah. Personally, well, this is the same with borderline diabetes. What does that even mean? Or pre-diabetes, what does that even mean?
Yeah.
You either have the process going on or you don't. Just because you haven't hit the number, what we should be doing is we should be looking at a microscopic level at patients and seeing if they are developing those changes that would be associated with, let's say, diabetes, or testosterone deficiency. And if they have that, then that is the thing that, to my mind, should guide treatment. Either symptoms or that. The problem here is, when you have such limited research, how long are we going to wait? Who's going to do the research? Where's the money going to come from? Who's going to do the research? And how longer, that could be another 100 years. That should not equate to, there's no evidence it works, so we're not going to even bother with it. What it should be is we should be open to the idea that, despite science making all the advances, we only choose to see that which we look for. Research is based around people wanting to look for things that are going to be profitable and create headlines. Research is no longer based around asking a good question and carrying out the experiment for the sake of answering a good question. It doesn't matter whether it's right or wrong, whether it's profitable or not. The idea should be you ask a good question. There's enough about testosterone in the literature to ask a question, to say, hang on, let's take a bunch of people, let's give them some testosterone, and let's define a value, or let's look for evidence of something that makes us think that this person may be lacking. Let's treat them, and then let's count the numbers. Let's see what happens. That's what we need to do. The problem here is that these are not going to be carried out because, to my mind, a lot of research is carried out by pharmaceutical companies. and it's all a little bit sort of political and vested, and you know. So I think it is really important for patients to know about the importance of testosterone.
Are you saying that it's because you don't see these large surveillance studies, like there was the Jupiter study for heart disease, these grand scales? You're not seeing those for testosterone, but there is a lot, like you said, smaller studies and even mid-sized studies that do demonstrate in the literature people getting better with testosterone. And I mean, I've been on testosterone treatment for 24 years. I know I'm an N of 1. You can't pay me a peer-reviewed study and get me published, but I think there is some benefit, and we can see it. And it's not like testosterone is a brand new drug. It's been around for like 75 years. So many other people have tried it, but I think there's also a taboo around testosterone, and it gets linked with doping and so many bad things in society that the medical community just doesn't want to look at it. Until maybe more recently, now we're starting to see it opening up. But endocrinologists, yeah, well, I not to knock them, but I feel like they need to have their title removed from their name, and they need to be called average diabetes specialist, not even good diabetes specialist, because if they were good diabetes specialists, they would actually consider testosterone treatment as part of diabetes treatment. Anyway, that's my rant over.
I think I would agree with you. I mean, the first thing I would say, N equals 1 is enough when it comes to quality of life, because your quality of life has to be measured by your yardstick. If you're saying, look, 24 years, I've taken it, I've not come to harm, and my quality of life has improved as a result, that's enough.
Yeah.
Yeah.
I don't need a study saying 2 million Siberian men felt better with testosterone. You know, that is less persuasive to me than you saying, I had a problem, I took this and I feel better.
Yeah.
Right.
That's the, you know, with thyroid treatment using desiccated thyroid. I mean, I've got some books on it. Is that the pre-accurate blood testing, it's nearly been used like in Europe for nearly 100 years now. They looked at symptoms that were commonly associated with it because it was deductive reasoning. You know, it could be associated with other things, but you get a group together and it's more likely to be this. And you tried them on thyroid treatment, and you treated them, and if they got better, they got better, and that was the treatment that was successful. You know, they didn't need to meet a number or reach a certain number to say that we've achieved this. And it is those outcome measures. It is the regulation, isn't it, of certain things that can sometimes, you know, be disruptive. And I think that's what we're missing. There are a lot of men missing just hormone therapies in general around the world because of that regulation.
From my perspective, what you need is a big scale study to show that it's safe, that people do not come to harm with it. And then it should definitely be prescribed for quality of life purposes. Whilst there's more data accrued in terms of large scale, big studies saying that, okay, in the small studies, we have seen this benefit. Can this be translated in a bigger population of patients, etc. But to my mind, I cannot see why, when a deficiency impacts on a person's quality of life, and there's a treatment available that can improve that person's quality of life, why we shouldn't consider it unless that treatment was an unsafe treatment. And there is really there's no evidence to suggest that in a supervised environment that it's dangerous. In fact, the FDA looked at this, didn't they? And they found 4 studies when they looked at everything, and they found 4 studies where they thought, testosterone was harmful. Again, not good studies, no real conclusive proof. Over 100 studies which showed that testosterone was beneficial. So to my mind, you have to do the study. You have to take away some of this kind of unjustified fear. You have to do a study, demonstrate that it's safe, and then you have to make it available to those patients who need it.
Yeah. I mean, if those studies just didn't show harm,
exactly,
but improved quality of life, I think that would be good enough. But they showed benefit, right?
Yeah. I mean, absolutely. But to my mind, I think that, okay, you can imagine people being reticent and saying, okay, well, these are small studies. We want a big study. We want a 30-year outcome, a 30-year follow-up, and see whether and that's the kind of study you need to know to see whether the benefits are truly translatable. Because when you have very small studies, you'll get big, you get this funneling effect as your population size gets bigger and bigger, right? So the benefit is less and the harm is less. But to my mind, it is only about this issue of harm. And so far, you cannot say that there is evidence that it is harmful at this point in time. And if it is beneficial and the patient can measure the benefit because they'll feel better, then I don't see a problem with it.
So I was going to say, even after all those studies, then is it going to be the nice group, or say we only want UK studies because it won't be relevant if it's coming from other parts of the world, which they say on so many things. They only want to look at UK data, which is a bit odd.
I mean, nice, again, they look at cost effectivity. I really feel that you cannot, and their guidance is delayed by God knows how long, even if something comes up. So where there are people who may be suffering, I think people need to feel empowered. People need to be educated on testosterone. They should feel empowered to go and ask for a test. They should feel empowered to ask whether the test really tests what it's meant to test and is being done by someone who understands the test.
Yes.
And they should be empowered to go and seek people who do know about testosterone so that they can potentially improve their quality of lives.
So this is a problem that we see with lots of patients that come to us already, and they give us blood tests that are about 1 year or 2 years old because they did go to their GP. And the GP said, "Oh, you're fine, you're normal, it's great." But when it's looked at a bit closer, you say, well, actually, that's not optimized, that's not normal. And they're only looking at it like they may look at all the other reference ranges, but that GP didn't really have a good understanding. They didn't look at your free testosterone, they didn't look at your SHBG, they looked at one number, they didn't listen to your symptoms, and they said, okay, go away. And so then 1 year or 2 later, these poor men have gone through this struggle of, what's wrong with me? All right, I'll go on an antidepressant, and then finally come to us where we run the proper tests and have the right doctors looking at it in the right way, and then the life changes for the better, and it's really nice to see the turnaround.
Okay, so thank you, Dr. Gupta, for joining us today. I hope the viewers found that helpful. If you would like to listen to more information and get more information about this, please subscribe, ring the notification bell because you'll get notified of more content like this. And thanks for joining us. So we'll see you next time.
Okay, see you next time. Thanks.